I'm Darren Morton.
I'm Simon Matthews. This is Lift,
The Lifestyle Medicine podcast, where we dive into the science of health and well-being.
Good afternoon, Professor Morton.
Good.
Nice to see you.
It is afternoon. Is it afternoon for you yet?
Absolutely not. It's morning for me.
That's why you look so fresh.
That's exactly right. Yes, definitely morning. How are you?
I'm well. I just
Very fine.
went snow skiing for the weekend. We took a group of university students up to the slopes. So we had some first timers who overcame some challenges, and so they were happy. And then we had about two AC joint injuries.
I was about to ask about the injury tally. Okay, so we've got two ACs. Any broken bones?
Don't think so. Although one girl's her forearm's not looking so great, so we sort of figure there's about a 5% injury rate.
Okay. When you say her forearm's not looking so great, are you meaning, for example, there's a 90-degree bend where there shouldn't be? Or...
No, not quite. It's just a little bit inflamed.
Okay. All right. So no breaks, but some inflammation and a couple ACLs.
Yep.
All right. So the orthopedic surgeons listening to this will be, getting ready to go to work.
Yeah.
Yeah. All right.
Ready for adventure.
Well, what I want to talk about today is a topic really for lifestyle medicine clinicians of all sorts, whether they're physicians or psychologists and coaches like I am, or dietitians or exercise physiologists, doesn't really matter. And in fact, we don't even need, I think, to limit this to lifestyle medicine. You can be a health clinician in any domain of healthcare, and I think this topic is going to be relevant. And it's a topic focused on a word that I've been familiar with for, I'm going to say 35 years at least. And it's a word that's often used to describe a patient or a client. And you may have even heard someone talk about this yourself. If you're working with a particular patient or client and they're not implementing your well thought out strategies and plans, what's the word that you might use to describe that person?
Resistant to change.
Yeah,
that's
exactly
not one
right.
word, is it? But
no, but resistant to change, and there's some variations of that, and I'll actually share some of the variations shortly. But this idea of resistance to change has been with us for it's been with us for a long time, and in fact, the very first instance of resistance seems to be in the writing of Sigmund Freud towards the end of the 19th century, so 130 years ago now. And the challenge that we have here is that many clinicians, I don't think with any bad intention here, inadvertently frame resistance as almost a personality feature of the patient. So if I describe you, Darren, as resistant to change, or if I've asked you to do something and you don't do it, and then I comment to someone that you're resistant, what I'm really doing is embedding that characteristic or quality inside you. And that's I think problematic for a number of reasons. So what I want to do today is have a conversation about the origins of this idea of resistance, where it comes from, what it means for us now. And I'm going to propose two different ways of thinking about this that I think, first of all, don't sort of saddle the patient with this characteristic. And secondly, provide us as clinicians a way forward instead of sitting in that experience of frustration and what do I do now and so on.
Mm.
So if we look at the history of resistance, as I said, the first evidence I can see is with Sigmund Freud, and Freud was very interested in the role of the id, the ego, the superego. So if you, in very straightforward terms, and I'm probably doing all those who understand Freudian ideas a great disservice here. But if you think about the id as the part of you that wants to satisfy urges and desires, you think about the superego as the part of you that moralizes and sets standards and has values. They're kind of always in a bit of a tug of war with each other. There's a part of you that wants to, run off and eat chocolate ice cream, and there's another part of you that says, but wait, that costs money and it's not good for your health and so on. Sitting between those is the ego, and this is I guess the part of us that does the mediating work between the id and the superego. And in Freudian analysis and Freudian psychotherapy, all of these parts of ourselves need to be examined. They're often, if you like, split apart with their own voices, and a part of the therapy at least is to attempt to bring some unity back to these parts.
Just out of interest, what's it?
Yeah.
Do you know what id? Where does that terminology come from? What does that actually mean?
Well, it's a Latin word.
Okay.
Id. Yeah. Yeah. Which means it, I believe. Yeah.
No relation
So
to id, iot. No, id.
No, it's the id. So in Latin, if you were to say id est, that translates literally as it is. So so the word id is the it of you. Yeah. So so Freud's idea about resistance was that during the course of analysis, he would be probing and exploring people's experiences, and people would often have or would have had past traumatic experiences, which are, remembered at some level in their mind, even if they're suppressed. So the memory, if I can use that word, doesn't need to be a conscious memory in Freudian thinking. It can still be a suppressed memory. Your body, your mind, your soul still remembers this experience, even if you can't give words to it. The process of therapy, of course, is designed to bring those things to the surface. And Freud said, well, sometimes these things are so painful, the mind has its own protective mechanism to prevent the person experiencing this trauma again, experiencing this devastating recollection. And that's what he called resistance. The resistance was simply a resistance to sharing verbally and openly this past experience. But even there, notice that there's a functional idea to resistance. It's not resistance for its own sake. It's resistance because it's your mind protecting you from something in Freud's thinking. If we go forward a little bit into the 20th century, Anna Freud, who was the daughter of Sigmund Freud, she was his youngest and sixth child, also a psychoanalyst. She reframed resistance slightly and called it ego defense. So it's kind of a what would I say? I'd call that a nuancing of Freud's initial idea. If we keep going, maybe another 20 years on to the time of Carl Rogers, who was most well known for practicing humanistic therapy, Rogers saw resistance as arising from the therapist kind of failing to accept the client as they are. And you might You might remember that phrase from Rogerian therapy, unconditional positive regard. This idea that a key function in any therapeutic relationship is to maintain this inassailable positive regard for the patient or client, and to accept them fully and completely as they are from moment to moment. So he saw resistance as, in a sense, a failure of the therapist to do that. Now, this is interesting because that represents the first kind of shift in thinking about resistance, and says it's not so much to do with the patient; it's actually to do with the clinician. So that was a bit of a significant shift. As time rolled on through the 20th century, in the 1960s and 1970s, we began to think of resistance as an effort to preserve autonomy. And I find that idea personally quite appealing. If I ask you to do something that doesn't align with your value system, your beliefs, your views of what's right in the world, then you're not likely to go and do it. And so you're most likely to refuse to do it and say, no, I won't. Now, I can label that resistance, or we can see that as you making an effort to preserve your own sense of autonomy and choice. You want to be able to do the things and make the choices that best fit for you. And in fact, go on.
Sorry, on that, interestingly, so you've linked that back to the idea of, that you talked about values there. But in that context, could it be that someone, that has under circumstances, that actually is something that they wouldn't be resistant to doing, they would like to do it, but the fact they're being, like, I'm thinking kids with parents. Yeah, exactly right. They're making a stand and almost cutting off their nose to spite their face, but because I'm the one I want my autonomy, and that's the preeminent goal for me, I'm going to push back, even though I probably would like to do that. I've seen this in young kids where that they actually do want to go and play with the other kids, but they've hunkered down and they're okay. Absolutely. That's interesting.
And autonomy development, of course, is vital for us as people. When I think I was about 7, I've got a cousin who's I think she's 4 years younger than me. So maybe I was 6 and she was 2, or I was 7 and she was 3. And her mother, my aunt, used to go off to her job during the day, and as a very young child, her daughter would spend the day with us at our house with my family. And I remember one particular afternoon, her mum arrived to collect her, and I went to help her put her socks and shoes on. And as I started to put a sock on one of her feet, she reached down, ripped it off that foot, and said, "This sock goes on that foot." So that's autonomy. That's even little kids, wanting to say, do you know what? I can choose things here, and I want to choose things, and I'm not going to do something that doesn't feel like it kind of lines up properly for me.
Not to get derailed, but what makes you remember a story like that at the age of 6?
Yeah, good question. And I'm one of those people who doesn't have, for whatever reason, I don't have huge numbers of childhood memories. And to be honest, I don't know whether anybody does really, but I've got little sort of snippets of memory here and there from very early childhood. I don't know, that particular one has just always stuck with me. For reasons I can't explain. But interestingly, on the back of this kind of move towards autonomy, and if you think about the time in the 20th century, we can match this up to some kind of broader cultural movements as well. This is the 1960s and 1970s.
Yes. Yeah.
So this is where autonomy is really beginning to emerge. In 1985, Ryan and Deasy published their now very famous paper on self-determination theory. And self-determination theory is I think a really important theory to understand in behavioural change. It's certainly an important theory to understand for health coaches and coaches of any sort. It's built on three foundations: autonomy, competence, and relatedness. So the autonomy component is certainly there. Following that, we saw a little wordsmithing starting to emerge, and this is where we get into some of these other more kind of nebulous descriptions of resistance. So people started moving away from the word resistance, which does, I think, carry some particular connotations to it. And then we started hearing things like avoidance or non-adherence or even non-compliance, which, I don't know, depending on your perspective, maybe that sounds a little bit softer and a little bit more innocuous. I don't think it substantially changes anything, because note where those terms, non-compliance, non-adherence, avoidance, note where they focus the choice and decision-making. It's actually in the clinician. If a patient is non-adherent, what are they non-adherent to? To what I'm telling you to do. So again, we're stuck with this problem that the whole idea here can be easily misconstrued as a characteristic of the patient, and in a sense a problem to be fixed. And then as we went on a bit further in the 20th century, we saw the rise of motivational interviewing and the trans-theoretical model of change at the same time. And those two things together, I think it's fair to say, would view ambivalence as a key driver here. So it's not that the person necessarily is being deliberately resistant, but they're ambivalent about the change and therefore not prepared to invest themselves in any particular action right now. So this history of this idea in treatment is interesting, because it starts with Freud, with this idea that it does exist and there's a reason for it existing. And then that reason sort of starts to get lost a little bit. Then we have Rogers popping up saying, well, it's actually the clinician that's not doing the work that they should be doing. And then we seem to drift back to this idea of it being a feature of the patient or the client. We move into these slightly softer sounding terms, but fundamentally we're still lumbered with the same idea. This is problematic for a number of reasons.
LIFT is supported by the LIFT Project, an educational adventure where you learn science-based ways to lift your mood and your life. The LIFT Project is lifting lives around the globe, in healthcare settings, workplaces, schools, universities and communities. To find out more, visit theliftproject.global.
One of the principal reasons is that it does nothing to question the power differential that exists between clinicians and patients. And that power differential is enormous. If you're an educated, qualified clinician who's being paid for the work that you're doing, that's a relatively very powerful position to be in contrast, for example, to someone who perhaps is struggling with the effects of difficulties managing their alcohol consumption or their tobacco consumption, or struggling with overweight or obesity or something like that. So while ever we're talking about this person being resistant, I think we continue to kind of keep the gap in power quite significant. There are two frameworks that I think that I've found helpful over time. that I think can really help us to move away from this. The first is a systemic framework, and you and I have talked about this. You and I have talked about systemic ideas in the past, and in this systems framework, we immediately understand that no behaviour occurs in a vacuum. So any behaviour produced by any person at any time always has some systemic influences around it, and we see this in lots of ways, even in everyday life. When I used to be a family therapist many years ago, one of the common scenarios that I used to see was what we would call the over-responsible, under-responsible system. We see this unsurprisingly in families, and you can imagine the presentation to a family therapist, a parent coming along complaining about their teenage child. Their room's messy, they don't put the garbage out, they don't do this, they don't contribute anything, they don't help out. I ask them to do this, blah, 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 and nothing happens. So what does the parent do in response? They step in and they do these things. They roll their eyes and kind of huff and collect up the garbage and go and put it outside. They huff and roll their eyes and, put a vacuum over the floor or pick dirty clothes off the floor. The next time this situation begins to emerge, what's that teenager learning? If I just leave everything there, someone comes and picks it up. And the adult is learning, I'm just going to have to do this if I want what I want. So over time, these things deepen and polarize, and that tends to be the operation of systems until they find what's called a homeostasis, which is this kind of balance where things just almost without any other external influence now just keep going round and around. We see this in couple relationships as well. We see couples where, for example, one partner in a couple likes a lot of physical closeness and affection, the other partner not so much. So if the partner who enjoys the physical closeness, moves to create more of that in the relationship, the partner who doesn't like it so much might feel a little overwhelmed. So they just back up a little bit. What's happening now? Well, now the fears of the other partner are getting activated. So what do? They pursue even harder, and around we go. Yeah. Around we go again. The same thing happens in clinical relationships. The more that a clinician frames a client as resistant in their own mind, the more likely they are perhaps to double down on their efforts to get this patient to do a particular thing. The more they double down, the more that patient is going to express their own autonomy, or whatever way we want to frame that. But the outcome is they're less likely to engage in that behaviour, and that cycle can deepen very quickly until we get to the point where a clinician is expressing a great deal of frustration about the client. Why don't they ever listen? Why don't they do this? Why don't they do that? I've told them so many times they should be doing this. They just don't do it. And the patient experience is one of they just keep telling me to do this same thing, and I know it's not going to work for me, and now I feel helpless and hopeless, and I don't know what to do anymore. So nobody wins in that context. So the systemic explanation is one explanation for what goes on there, and if we understand it from that perspective, then what we actually see is that the resistance that we're calling is often clinician-induced resistance. So it's the clinician's own actions that are sometimes initiating, but at least perpetuating this so-called resistance. So the clue there, of course, is for clinicians to do something different. For clinicians to approach this from a different perspective,
and I think that the whole
to examine their own actions, and so on.
And clearly, the whole health coaching model and paradigm
Exactly.
is very relevant here. I mean, I think, and I like it, you can understand where people approach this as a clinician with that expert model. Like, I know how this goes. I know what should happen. This is what you need to do. You can understand. I would get my back up against that probably if I felt that my autonomy and my intelligence, I suppose, wasn't being respected in that regard.
Yeah. And unfortunately, a lot of our tertiary education in pretty much anything, but certainly in healthcare, still leans largely towards this model of subject matter expertise and content expertise. So
Yes.
we all of us who train as clinicians of one sort or another, whether it's an exercise physiologist or psychologist, dietitian, physician, we go to university, we spend a lot of years, we spend a lot of money doing what? Gaining knowledge and information. So there's this kind of subtle system influence that says to us, that's what you should value. You should value the knowledge and information you have, because that's what you've spent so much time learning, and that's what you've paid so much money to learn.
Yes. Yeah.
And of
it's
course,
interesting.
that sets us up to approach clinical encounters in that way.
It does. Yeah, it is interesting at because we both teach at university, but there is a move, increasingly towards adult education and understanding that we need to not be sages on the stage. We need to actually be guides by the side, and I think that's that's actually been a really helpful paradigm for me. Understanding that really this isn't about being that content expert that gets on and spruiks. Unfortunately, that's sort of the model I grew up with, and I quite like it. It's been quite challenging from an education perspective to realise that isn't what produces the best educational outcomes for people.
Exactly right. Yeah.
Often as teachers, that's what we want to do, is we want to teach. We want to be that person. And as clinicians, they want to be the carer, who provide, does the healing. But what we need to realise, we're seeing it in education. We're seeing
just as an aside, this is why I like the word educate, not teach. And if someone asks me, I describe myself as an educator, among other things. And the reason I like the word educate is because it has Latin origins, and the E part is the preposition ex, which means out of, and the ducate is from the Latin verb ducare, which means to draw. So literally, when you educate, you're drawing out of someone. And we need to be a little careful there, because I certainly don't want to go down the pathway of, expressing the view that somehow we're all full and complete and we have all the information that we all ever need within us all the time. We don't. Clearly, we need to learn some things as well. And at the same time as we're learning, going through that process of learning how to draw out that information and experience and then reassemble it in a way that's useful in this context at this time is really, for me, what learning and education are about. Yeah.
It's interesting. I remember about 15 years ago at the university where I'm at, they used to call it teaching and learning, and they switched it. They now talk about learning and teaching, because they wanted learning to be the front line. So it's all about, student-centered, client-centered. It's interesting. There's these dawnings that occur often in a number of different industries simultaneously. It's quite interesting connecting the dots.
Well, I often, when I went to university and studied psychology 30 years ago, I still say now that I walked out of my psychology program understanding and knowing intimately the 4 Ds: disease, disorder, dysfunction, and diagnosis. They were the things that I was trained to do really well. To know disease, to recognise disorder, or to name disorder, to recognise dysfunction, and then ultimately to diagnose. And thankfully, I had some both pre and post psychology training that enabled me to contextualise that differently. But this idea that the clinician is the person with the information that simply needs to be, if you like, pushed to the patient, itself often leads to the development of what we're calling resistance. And yes, you're absolutely right. Health coaching as an approach it essentially inverts that and goes about the process of health behaviour change in quite a different way. But there's another framework for understanding resistance that I think is really helpful here, and this is where I tend to spend most of my thinking time, these days, if I'm working in any context with someone who appears less than enthusiastic about making some sort of behavioural change, and that is the idea of the function of the symptom. In other words, in what ways does this stuckness help you? In what ways does doing nothing right now, or nothing different, help you? How is this beneficial to you? So there's two immediate shifts there. The first is that instead of just seeing something called resistance and labelling it resistance, I get curious about it. I get curious about why it's there. And secondly, I deliberately adopt this framework that assumes not that the resistance is irrational, but it's rational. It's serving some really useful purpose for this person at this time. So in what ways it is not making a choice here, or in what ways is not doing something to change this useful to you, is one side of the coin. The other side of the coin is to think about this. Why do we engage in any behaviour? So, for example, if you were to walk outside now to get a glass of water, why would you do that?
By some need.
Exactly right, to satisfy need. So thirst in that case. If you decide to eat now, you'll be satisfying a need of hunger. If you decide to go outside and start walking around, maybe your body is telling you, I just need to I need to move. I'm sick of standing or sitting here in this one spot. All human behaviour emerges because of some sort of need. Sometimes that need is recognised and even verbalised. Other times, I think those needs remain at an unconscious level, and we simply engage in the behaviour anyway. So, if we work from that premise that all human behaviour has behind it a need that we're endeavouring to satisfy, then the other option that we have in understanding resistance kind of goes all the way back to Freud, who voiced this in some small way, and that is, whatever you're doing or not doing, or saying you don't want to do, let's spend some time understanding why that's important to you, understanding perhaps what the need was, maybe even historically, that led to this behaviour. So let's put this in clinical terms. Let's imagine that we're working with a patient who is refusing or is resistant to engaging in physical activity. Well, our first port of call ought to be curious about that, to understand what might be behind that. The second thing is to ask, I wonder what the need could be here. Now, one of the ways of getting to needs is to ask someone, what matters to you here, or what's important to you here, or what concerns you or worries you here. All of those questions in one way or another will start to get us into the domain of human needs. So if someone, for example, were not engaging in an exercise program, I might ask the question, what concerns you about doing this? And then I might learn, for example, that the person had a knee injury. Maybe some kind but not very capable educator took them on a skiing trip years before, and they got an ACL injury, and they've been nursing it ever since, and they're really worried about the possibility of aggravating that. Now I'm starting to get to understand about a need that's driving a particular behaviour. And we simply don't need to engage with the idea of resistance at all. It's just a completely different framing of what's going on. It's a framing that says whatever behaviour you have at any time, it's a rational behaviour, not an irrational behaviour. It's there for a reason. That reason likely has a need of some sort sitting behind it. My job as the clinician now is to understand that need. And then, of course, we're able to have a discussion about how we might be able to simultaneously satisfy that need that you're expressing by way of a fear, but also the need that you're expressing by way of a desire for improved health or improved well-being or improved functioning or something like that. So in fact, from that perspective, resistance, if we want to call that, is not an obstacle. It's actually a resource. The resistance of the client that we see then becomes something that as clinicians we can use to help us to understand more about this person and then be able to move forward to support them to satisfy those needs as best they can.
Yeah, I like that idea. I think it really what it speaks to is understanding people's motivations, drives, and what's actually going on for them, as compared to putting this superficial band-aid on and making demands on people that might be valuable to them or of value to them, and there's these other impediments there that are preventing them from being that word resistant. So do you have a word that you prefer? Like if you had to, what's your preference for? I know that I've heard you use ambivalence often.
Yeah, ambivalence is not a bad way of understanding this. And again, I like the word ambivalence because of its Latin origins. Ambi meaning both, and valens meaning having value. In other words, if we're ambivalent, it means both this course of action and that course of action have some value to us. They're useful to us in some way. And that reminds us then as clinicians that our job is to understand and appreciate the value that both of those things bring. Once we can do that, then we're in a better position to move forward. To be honest, I probably tend these days. I probably tend not to even use a word to describe it to myself. I think in a coaching or a clinical encounter with someone, now these days I simply see what's there and I understand it and think about it in terms of an underlying need, and I get curious about what that need might be and the way in which the person has or hasn't been able to satisfy that need. And in doing that, we kind of bring that thing out of the darkness or out of the corner of the room into the centre of the room, where we can both examine and explore it in more detail. And of course, once it's there in the centre of the room, we can do something about it.
Yes, yeah. I always remember the story Dean Ornish shared, and he talked about a man that he was trying to help quit smoking, and the man, after some time, once said to him, "Hey, but I've got 20 friends in here. If I take them away, what do I have then?" And I think what, once again, this speaks to is understanding the deeper motivations, the deeper needs, the deeper desires, and probably one word that I've learned from you that often features for me quite intentionally is that curiosity. And I think, demonstrating that curiosity and trying to get to understand people's stories and all those, aspects of who they are and what's important to them, I think can make a tremendous difference, whether it's in education, whether it's in, clinical care, whether it's in general life. I think it's a really good word to practice.
Yeah.
Curious.
Yeah, absolutely. Curious. So I think that's a nice word to finish on.
It is.
Lift is presented by Simon Matthews and Darren Morton. It's sponsored by the Lift Project and supported by Avondale University. Music provided by Pixabay. If you have a question or a topic you would like to hear more about, send us an email to podcast@theliftproject.global. The Lift Project. Lift your mood, lift your life.